So hello and a very warm welcome to this Podmedics podcast on hip fractures. In this podcast we're going to look at some epidemiology, we're going to look at the various types of fractures, particularly focusing on intracapsular and extracapsular, and then finally consider some of the medical management principles that are important for the management of hip fractures. So let's get on with it. Let's first talk about the basic epidemiology, anatomy and classification. So the first thing to say is that hip fractures are very common, with roughly 75,000 occurring per year in the UK. This means that as a junior doctor, either working in orthopaedics or working in the accident and emergency department, you're going to see a lot of these patients. So it's important to know about hip fractures and what you do. The most common age group that you'll see this in is the elderly, particularly postmenopausal women. Risk factors for hip fractures include osteoporosis, and risk factors that are associated with any type of falls. So let's just remind ourselves about the crucial anatomy of the hip that you need to know to understand hip fractures. So this should be a familiar diagram. This is taken from Gray's Anatomy. Essentially, you've got the pelvis at the top, and notice you've got the ilium, the spine of the ischium, and the tuberosity of the ischium. If you're not familiar with these, go back and have a look at some of your anatomy notes. Then you've got the femur. Now for the femur, the part of the femur that inserts into the pelvis is called the head, and the head is surrounded in a capsule. Beneath the head we have the femoral neck, and beneath that we have the trochanters, the greater and lesser trochanter, and then a line in between called the intertrochanteric crest. This is important to know because we broadly divide hip fractures up into intracapsular and extracapsular. And the marking between is the insertion of the hip capsule into the femoral head. So fractures that occur proximal to the insertion of the hip capsule on the femoral neck are termed intracapsular, while those that occur distal are termed extracapsular. Notice also that we can classify extracapsular fractures based upon their location, and this can be either intertrochanteric or subtrochanteric, but more about this later. So let's start by talking about intracapsular fractures. The important point to note for intracapsular fractures is that they disrupt the retinacular arteries that run up to the neck. This means that if there is a fracture, the blood supply to the neck can be compromised, and after the fracture, the head of the femur can potentially deteriorate and collapse, a condition known as avascular necrosis. This is just a drawing to show what I mean. So as you can see here, you've got the retinacular arteries supplying the head of the femur and an intracapsular fracture that is disrupting these. So what does it look like on X-ray? So looking at this X-ray, you should be able to see that on the left-hand side, there is a fracture, particularly a hip fracture. The fracture seems to be proximal to the insertion of the hip capsule on the femoral neck. Therefore, this is an intracapsular fracture. So, how do we treat these fractures? The key to the treatment of intracapsular fractures is the level of displacement that you see on the X-ray. If the head is highly displaced, the head is excised and replaced, and we call this an arthroplasty. If the head is not really displaced, we can save it and fix it with screws. Some of you, I'm sure, have heard of the Garden classification. For example, that famous phrase, 1-2 screw, 3-4 Austin Moore. However, the Garden classification is not great, and recent studies have shown that there is considerable intra and inter-observer reliability. Instead, it's simply better to describe the fracture as either displaced or undisplaced, as we did before. So, let's first look at a hemiarthroplasty. You should be able to recognise one of these on an X-ray. As you can see here, we've got a large prosthetic femoral head that's sitting in the native acetabulum. Beneath that, we have what is termed a femoral stem that is fixed into the femur with surrounding cement. Complications of a hemiarthroplasty include infection at the site, dislocation in the future, and because the acetabulum is not replaced, sometimes the head of the prosthesis can wear through, causing acetabular wear. Here we see an example of screw fixation, and we can see cannulated screws that are holding the head in place. Complications of this include failure of the mechanism of fixation, causing a non-union of the fracture, loss of position of the distal or proximal side, and sometimes femoral head avascular necrosis. Okay, so let's now move on to extracapsular fractures. As we described before, in an extracapsular fracture, the fracture is distal to the capsule, so there is no risk of avascular necrosis. Extracapsular fractures may be either intertrochanteric or subtrochanteric, and they're also often divided by the number of fracture parts that result. This is an X-ray that shows a fracture of the right hip. The fracture appears to be in multiple parts, but the main fracture line appears to be distal to the insertion of the capsule. This is therefore an extracapsular fracture, and I think it's probably intertrochanteric. So let's now consider the management of intertrochanteric and subtrochanteric fractures. So intertrochanteric fractures are usually fairly stable, and unless they're complex with lots of pieces, we usually treat them with a dynamic hip screw. On the X-ray here, you can see an example of a dynamic hip screw. You can see a very large screw holding the femoral head, and this is inserted into a plate which is attached to the femur with screws. The screws grip the femoral head and can slide down through the plate barrel, allowing the fracture to compress and hopefully to heal. However, if an intertrochanteric fracture is very complex, for example in the X-ray that we saw before, we may wish to use an intramedullary nail. In a subtrochanteric fracture, we need to consider that these fractures are not very stable. So they're treated with an intramedullary nail, which we can see here, and also a screw. So that's the basics of the different types of fractures and the various prostheses that you're going to see on X-rays. However, a very important thing about this group of patients is they're often elderly and often they have multiple comorbidities. In fact, the prognosis following a hip fracture is worse than some cancers, with around 10% dying within a month and a third within 12 months. It's therefore very important to apply vigorous medical therapies to these patients and to try and optimise their health before discharge from hospital. The main things to consider are the prevention of venous thromboembolism, which is a particular concern in orthopaedics. So these patients would, of course, wear thromboembolic stockings and be given low molecular weight heparin. Particular care should be taken to mobilise these patients as early as possible to get them going, to prevent chest infections and to prevent pressure sores. All patients should be reviewed by a geriatrician after they have had their operation. The aim of this is to try and prevent future fractures and to optimise the healing process, and often bone protecting agents such as bisphosphonates are given to this group of patients. So, I hope you found this podcast useful. See you again soon.